Thank you. And I'd like to give a shout out to our podcast on women's health, the 7 Domains of Women's Health. If you haven't heard about it already, we've done with the most wonderful Katie Ward. Dr. Katie Ward is my co-host now. And Katie is a women's health nurse practitioner and knows more about progesterone than anybody probably now in the Intermountain West, given it's her focus of her PhD thesis. So please check in the 7 Domains of Women's Health anywhere you get your podcasts, 7 Domains of Women's Health. I want to give a shout out also to Germans. And the reason I want to give a shout out to Germans is Germans had the best organic chemists in the 1800s. And they were looking for a way to make cortisol. So cortisol was the most amazing miracle drug of the late 1800s. And they knew, and the shout out to Germans because they like sausage. And sausage is usually made from pigs. There were lots of pigs, and they found that they could get cholesterol out of the gallbladders of pigs, and then they could start the long and very tortuous process of making cortisol from pig cholesterol. Along the way, they noticed in the ovaries of these pigs that there was this yellow stuff and these little yellow bodies in the pig's ovaries that exactly correlated with the number of piglets that they had. So they said these little yellow bodies, which was the follicle that was making progesterone, and they called them luteotropin or luteosterone, light body, and then they discovered progesterone. So in the late 1800s, progesterone structure was discovered, although the production of progesterone and then also estradiol, it was so hard. So they had to try to get it from animals until another great German went traipsing around into the middle American jungles and found a very large yam. It's not edible, and had a precursor that took out a whole lot of steps in the production of cortisol and estrogen and progesterone and testosterone. And he used the marker synthesis to make the steroids that we use every day. But now we have many different kinds of steroids, thanks to this, many different ways of delivering these steroids, and that's going to be the topic of our conversations today. Individualizing therapy, new drugs that might be available. Do you put it on your skin? Do you stuff it up your nose? Do you put it in your vagina? Where do you put it? And just to help us start with this is Dr. Camille Moreno. And we are so fortunate to have Camille here with us at the University of Utah. She is the director of the Women's Menopause and Midlife Health Clinic. She did her training at the Cleveland Clinic and then went on to be faculty at Duke before she came here. And she has really helped focus our focus on midlife women's health and on hormone replacement. So welcome, Camille.
Thank you so much, Dr. Cartley Parker-Jones, the trailblazer in our field, for that kind introduction. So we're going to continue our menopause talk because it is an exciting time to be in the menopause space this year and in the last year, as you all have heard in the news and social media. And hopefully I can advance my slides. I have one disclosure to share. So I would like to provide a brief overview of the FDA-approved indications for the management of menopausal hormone therapy. So as you all know, it is still the first-line therapy option for hot flashes and night sweats for individuals who are overall good candidates for menopausal hormone therapy. Mackenzie, who is the speaker coming up after me, will be discussing those contraindications as well as medical conditions that will be at high risk for hormone therapy use. So we also know that menopausal hormone therapy, it does reduce bone loss and reduces fracture risk among postmenopausal women. We know that based on the Women's Health Initiative data, and it is FDA approved for the treatment, the prevention, not the treatment of osteoporosis. And in the setting of premature hypoestrogenism, so this is premature ovarian insufficiency, premature menopause, so when menopause happens before the age of 40, or when a woman undergoes removal of both ovaries surgically at surgical menopause, it is detrimental to replace women's estrogen. And we do use, lastly, menopausal hormone therapy as FDA-approved indication for the management of genitourinary syndrome of menopause, which is a mouthful. We call this GSM for short, previously known as vulvovaginal atrophy. And this encompasses basically anything that involves the genitourinary tract, including pain with intercourse, vaginal dryness, UTI-like symptoms, and the risk for recurrent UTIs also increase at menopause. So this is a slide of all the types of estrogen therapy that are FDA approved here in the US. So you all may be familiar with conjugated equine estrogen, also known as Premarin in the market, which is the most widely studied estrogen type in randomized controlled trials, and it's been available since the 1940s. It is purified from the urine of pregnant mares, hence the name Premarin, and it consists of a mixture of 20 estrogens, including estrone and 17-beta estradiol. It does have both FDA approval for all these indications that you see here: vasomotor symptoms, GSM, and prevention of osteoporosis. So micronized 17-beta estradiol is another type of estrogen, estrase in the market, and this is widely used not just in the US, but also among European countries. And it is the only bioidentical estrogen type that is FDA approved here in the US. And similarly to Premarin, it has FDA approved indications for vasomotor symptoms, prevention of osteoporosis, and GSM. Some of you may know about esterified estrogen, which is Menist in the market. This is an oral synthetic estrogen containing about 75 to 80% of sodium estrone sulfate, and it is approved for vasomotor symptoms, but not for prevention of osteoporosis and not for GSM. So more estrogens, right? So ethinyl estradiol is not menopausal estrogen therapy. It is actually the estrogen type that is in combination contraceptive pills, vaginal ring, or birth control patch. Estetrol, which is now the emerging newer estrogen type, is also called E4. And this is a natural occurring estrogen type produced by the human fetal liver during pregnancy. And it has been shown to inhibit ovulation and treat vasomotor symptoms in perimenopause. It is available in a combination oral contraceptive pill called Nextstellis. So estetrol plus drospirenone actually makes up Nextstellis. It is not FDA approved for vasomotor symptoms, GSM, or osteoporosis prevention, but we do use it off-label for perimenopausal management, especially for women in that stage of life needing contraception. So in the next two slides, we're going to differentiate oral estrogen types versus transdermal estrogen and vaginal estrogen. So historically, oral estrogen, again, like what I mentioned earlier, has been widely studied. And it does go through the liver and also the GI tract or the gut. It can increase the high-density lipoprotein cholesterol or HDL cholesterol because it goes through the liver, and it can also increase triglyceride levels by 25%. Since it goes through the liver, it can stimulate the production of those clotting factors, inflammatory markers, liver enzymes, liver proteins, and also keep in mind that it can also increase sex hormone binding globulin or SHBG, which is a protein that binds to free testosterone in the bloodstream, and it can have a negative effect on sexual functioning and can lower libido. Versus transdermal. Transdermal is available in many different formulations, including the patch, the gel, spray, emulsion, and a vaginal ring. And unlike oral estrogens, the patch or transdermal options are not subjected to first-pass hepatic metabolism, so they bypass the liver. And it can lead to steadier state of estrogen levels in the bloodstream. And most transdermal formulations, as we've heard today, are estradiol, so bioidentical type of estrogen. And it has no effect, or I guess it doesn't negatively affect sexual function because it doesn't increase sex hormone binding globulin. Moving on to progesterones and progestins. So We've heard about micronized progesterone being asked earlier. And so based on data, micronized progesterone actually has not been effective in sleep, although anecdotally, I do mention to patients that if you take it with food at bedtime, you will benefit, hopefully, from the sedating side effects. So for perimenopausal and menopausal women who have nighttime symptoms, including hot flashes at night, night sweats, sleep interruptions, micronized progesterone is a good option. It is contraindicated in women with peanut allergy because it is mixed in peanut oil. And also keep in mind that this is the only bioidentical progesterone that is available here in the US and approved by the FDA. Synthetic progestins come in many different formulations. Oral is what we use to protect the lining of the uterus. There is no vaginal progesterone that protects the lining of the uterus. We do use that off-label, but mostly used in infertility treatments. So the different synthetic progestins available include norethindrone, norethindrone acetate, drospirenone, as well as medroxyprogesterone acetate or Provera, which was studied in the WHI. So what about alternatives to uterine protection? So we do use off-label levonorgestrel containing IUDs at 52 milligrams to protect the uterus against the unopposed effects of menopausal estrogen therapy. So we use Moreno or Liletta. Duove. So some of you are also familiar with this oral TSEC, which stands for tissue selective estrogen complex. And what that means is it includes both Premarin plus beta-doxephene. But beta-doxephene is not a progestin. It's actually an estrogen receptor antagonist that provides the protection at the level of the uterus from Premarin. And this is an FDA-approved oral menopausal hormone therapy for prevention of osteoporosis as well as treatment of vasomotor symptoms. And currently, actually, Duove is being studied in DCIS patients in a study called PROMISE. And so we also are learning that beta-doxephene may also have antagonistic effects at the level of the breast tissue. So what does it mean when we say bioidentical? And actually, Mackenzie will be explaining this in more detail, and Cash as well, who follows Mackenzie after this. But basically, these are hormones that have the same chemical structure to the hormones produced by your ovaries during your reproductive years. Bioidentical is actually a marketing term. It is not recognized by the FDA, and it is often misused by many anti-aging clinics here in Utah and beyond. And so they are inaccurately marketed as natural or safe, but really, the Menopause Society and ACOG have released position statements against the use of bioidentical compounded hormone pellet therapy. They lead to supraphysiologic levels of hormones, including testosterone, more than a biological male. They are not FDA approved. They are not regulated or monitored for purity or safety. So when do we replace women's testosterone? I mentioned this earlier. I do tell my patients that there is a role in replacing women's testosterone, but there is no testosterone formulation that is FDA approved for women. And so we use this off-label for the indication of hypoactive sexual desire disorder or low libido for postmenopausal women. And so we judiciously use 1/10 of a dose of what we would give males. And we do serially check testosterone levels, typically 6 to 8 weeks after a testosterone cream or a gel is initiated, and check testosterone levels after that every 6 months. So what are the contraindications to hormone therapy use? I know Mackenzie also has a similar slide, which she will be talking about in more detail, but typically unexplained postmenopausal bleeding or abnormal perimenopausal bleeding that has not been evaluated, prior history of estrogen-sensitive cancer, whether it's ovarian cancer, endometrial cancer, breast cancer, having had a triple negative cancer. However, there is a caveat to this. We may consider hormone therapy in symptomatic individuals who have tried non-hormonal options, typically 5 years out from their diagnosis or have completed treatment. history of coronary artery disease, cardiovascular events such as stroke, heart attack, history of a venous thromboembolic event, or an inherited predisposition, severe active liver disease, and I mentioned earlier peanut allergy for micronized progesterone. So in conclusion, who is the best candidate for hormone therapy? So women who initiate hormone therapy within 10 years of menopause onset, preferably before the age of 60. Those who have indications to start them, including symptoms that affect women's quality of life, sleep, mood. If they have osteopenia and may want it for prevention of osteoporosis, but also have the menopausal symptoms, and overall have no excess cardiovascular disease or breast cancer risk, and who are overall healthy candidates within 10 years of menopause onset. And I believe we're going to take questions after. Thank you.